there was strong correlation between the DBS and also the conventional labs for C4, C1, and also C1 function. So this was the 3 tests that were available in our dried blood spot. And the good news is that there was no false negatives.
Hello guys, and welcome to this next episode of All Things Angioedema HAE, your A-Care podcast. My name is Thomas. I'm your host, as you already know, and I have a new speaker today for this podcast. The diagnosis of HAE is actually based on medical history and laboratory testing. This is really what the guideline says, and this includes testing for quantitative C1 inhibitor levels on C1 inhibitor function and level, and of course measuring C4 complement. And these tests are widely available in Western countries like in Germany, where I am living. But in resource limited parts of the world, like the Asia Pacific region, these tests the colleagues have really limited access to these tests. And this really prevents patients from early diagnosing, resulting maybe in unnecessary procedures, hospitalization, incorrect treatment, and even death. So this is really something we need to take into account when we talk about these tests when testing people suggested or maybe suspected of having HAE all over the world. In this episode, I would like to discuss about alternative methods, and one alternative method to establish the laboratory diagnosis of HAE. And as I said, I have a new speaker in this podcast, and I invited Jane Wong. She is here, who was really much involved in the validation of this method we want to talk about in her region, and also its utilization within the screening program. So hi, Jane, how are you doing?
Hi, Thomas. Hi, I'm doing good. Thank you. Thank you so much for the invitation and the chance to talk about this topic.
Great, and thank you very much for agreeing to be my speaker at this episode. I know it's already late. Where are you living at the moment, and where are you sitting at the moment? So maybe, Jane, it would be great for the people who are listening to this episode that you briefly introduce yourself, and that also then everyone knows who you are, where you're from, and what you are doing.
Sure. I'm Jane. I'm from Hong Kong. It's currently 11 p.m. and really, usually it's the start of our days. No, I'm joking. So I'm an immunology allergist. I look after adult patients, and I work in Queen Mary Hospital, which is one of the tertiary hospitals in Hong Kong.
Great. So we all know Chinese physicians are working hard. That's great. And now it's 11 o'clock. So as you said, 11 p.m. usual time to continue working. So we are really happy to have this episode with you recorded. So maybe as an introduction, Jane, I talked about C4, C1 inhibitor levels, C1 inhibitor function. These are conventional options for laboratory testing. And could you maybe explain how these tests are usually performed at the moment? And secondly, maybe on the challenges some regions may face that in the end led you and your team work on alternative methods.
Yeah, sure. So we're quite fortunate in Hong Kong. So in Hong Kong, we have all the conventional tests for HAE, and that includes C1 inhibitor and function. So in Hong Kong, we mainly use, but I know in many other centers, nephelometry or, radioimmunodiffusion might even be used. And same for C1. So for us, we use a method called nephelometry. And C1 function, we also have that in our laboratory. So conventionally, at least in our laboratory, we use a chromogenic assay, but I do know, some other centers might use ELISA or so forth. For us, actually, initially, it wasn't a big of a problem in our locality in Hong Kong per se. But because we are the only tertiary center in Hong Kong with these tests, so if you were a patient with HAE or suspected HAE and you wanted to do these tests, you would have to arrange specifically with our laboratory. And fortunately, Hong Kong is quite small, serve a population of almost 8 million people. But if you were to take a blood test, especially C1 function, which is you need to send it quickly to the lab, then it has to be sent immediately, and we needed to have a prior discussion with our lab colleagues before it could be sent to make sure we don't have any false negatives. But you were mentioning that, in other localities, in other regions, not so far from Hong Kong, they're not as fortunate, and these laboratory tests are tedious. They do need vigorous laboratory accreditations, and it's just not feasible to have all these kind of specialized tests in every laboratory. And I'm sure, we've discussed before, but especially as you mentioned in the Asia Pacific region, we did a survey a few years ago asking, all these HAE centers around Asia Pacific. And unfortunately, only 70% of these facilities have C1 inhibitor level, and even less so for C1 inhibitor function, which is really important for the diagnosis of HAE type 2 especially. So that was an issue. And as you rightly mentioned, if you don't have the right laboratory diagnostics, then we can't make the diagnosis of HAE, and that really hinders, treatment and management of these patients. Yeah.
Right. So this was one of the surveys. Also, Philip Lee,
Right.
Dr. Philip Lee was first author, and this was one of the results that many regions have access to C4, but maybe also to C1 inhibitor levels, but are lacking C1 inhibitor function. Maybe let's keep one question I have. So in your laboratory, when you want to have C1 inhibitor testing, how long does it usually take until you get the results? And are there any obstacles or any things you need to be cautious with the interpretation of the results you receive from these lab tests?
Yeah, so for C4 and C1 inhibitor level, maybe the turnaround time would be a few days. We would have it 3 to 4 days. For C1 function, perhaps a little bit longer, but it really depends. If we put in a word with our colleagues, maybe it'll be a bit faster, but around 1 week, I would say, the turnaround time. Yeah, but as I was mentioning, especially for C1 function, we do recommend the bloods to be sent directly to the lab, and hopefully within 2 hours, because if you delay any longer, then that would lead to falsely low results because of the process.
And maybe also the lab tubes shouldn't be too long. So the measurement of this test should be quite fast until
Yeah,
it
so
shouldn't stay
we
too long
were
in the tube,
so
right?
once we take the blood, we would send it directly to the lab. For me, I don't even wait for the porters in our lab. I actually have to, bring the bloods to the laboratory. If they were sent in from other hospitals, they would need to be processed and transported on dry ice, preferably. If it's same day, then perhaps room temperature, but it has to be within the 2-hour window frame. That would be the most ideal.
This would be ideal. So actually, not the issue with the lab testing and how fast the blood is processed was the reason why you worked on the development of a new or validated an alternative method. There was actually more like the reason with the availability of lab testing in, let's say, under-resourced countries. So could you maybe elaborate a bit more on which was the method you validated and how you actually did this? Did you use patients for this, or was it just a lab test you validated? So how did you do it?
Yeah, so what we did was we found patients with diagnosed HAE, either by a C1 level or a C1 function, depending on the types of HAE. And then we invited them to come in to do dried blood spot. So the method that we did for the dried blood spot was either at the clinic, or we also offered community visits by our nurses. And they would bring the kit, to their to their homes to do the dry blood spot test, and it was very easy. It was just either we use a finger prick or we take a little bit of blood, very easy on a card, and then they could. And then we would just put it in an envelope, let it dry out for a couple of hours, and then on the same day we were able to ship it out to the labs, and then we would get the result. I think it was around 10 days, and we would get the results back. So these patients already had their laboratory tests, and then we would use the cutoff values on the DBS that was predetermined to determine whether it was low or not low, and then corroborated that with like the conventional tests. Yeah. And then looked at, did correlation analysis.
How did the correlation analysis look like? So were the results of the DBS card you received for C1 inhibitor level C4 comparable to those from conventional lab tests?
Yeah, so it was very promising. There was strong correlation between the DBS and also the conventional labs for C4, C1, and also C1 function. So this was the three tests that were available in our dried blood spot. And the good news is that there was no false negatives. So which means that if you had a DBS that said you do not have HAE, when you don't want to have a DBS that says you do not have HAE, when in actual fact you do. So that means that although we might not be able to completely replace conventional studies because we still need to confirm it, but it is potentially a very good screening tool.
Great. So you said the blood just from the pricking on the fingertip is enough so how many spots should be filled? Is it one spot? Is it two spots? Or
it was 5 spots. It was five spots. So it did require, the either 2 pricks, or actually we found that it might have been a bit easier just to take a little bit of blood, draw a little bit of blood, and then did the spots. But even still, it was very easy to perform in a community basis, especially when the patient did not want to come back to the clinic specifically to do these tests.
Great. So you said how many patients did you include to validate this?
So the first part of the validation was 16 patients, 11 type 1 and 5 type 2 patients, and they came from 7 families altogether. So it was a good mix of the 2 types. And then the second part of the study, we actually tried to use the DBS for family screening. And this was even more exciting. So these are patients and families that we already have pretty good rapport with them. We've known them for a few years, and once they come in to our clinics, one of the first questions we'll ask them will be like, oh, did you bring your family, your relative, your aunt, your uncle? And the people who agree to come would have already came. But it was really exciting because there were actually additional family members that originally would not have attended our clinics, but we were able to say, oh, we have a new, method of testing. You don't have to come to the clinics. We'll come to you and we'll do it. This DBS is free of charge for them, and they were willing, and we were able to find in one family, we were able to find like 9 relatives that would not have come if not for the DBS. And I think within those 9, there were ultimately, after confirmation with the conventional tests, 2 were diagnosed with HAE, and we were able to provide the medications for them in case they have an attack.
Wow. So that sounds really like a straightforward approach. So really good news. On the other hand, are there any maybe limitations of the way of this method or of this way you get these tests done one should know about?
Yeah, I think, well, obviously one limitation is it's a very small study. We only had what's like 16 plus 9 patients. So we would need bigger studies to carry out better validation studies. And we do need more normal controls, especially if you were to implement this on a wider kind of use. So if you're doing like a general population screening of angioedema. We want to know if the DBS is good enough for that. I think we obviously compared with our own methodologies. So if your laboratory was using something else, that would not be applicable. So yeah, we're very excited to carry out bigger studies, more centers, more validation to your own laboratory tests to see how we can utilize DBS in
Great.
different
So
regions.
DBS screening, as you said, this is, it could be used for family screening for bigger project, as you said, though. So you're really looking for, so the material, the blood is collected within a dried blood spot card. And I think that's a really interesting method. And obviously it's quite safe to store this for a while. Also, how long can this blood drop or dried blood spot be stored? And are there specific conditions needed to store this
Very
card?
easy. So once we filled in the 5 spots, you need to air dry it. So their instructions were that you just need to let it air dry. Don't, use a blow dryer to quicken the process. Just let it sit. And then after, they advise you to sit for maybe 2 to 3 hours. And then they would provide you the envelope and you can slip it into the envelope. And then just ship it. And then so you can ship it on the same day, or you can actually collect all the DBS, put all the envelopes in your office a week, and you can still ship it in one go, depending on how convenient it is for you. So once you have the blood spot, it is very stable, very easy to transport. You don't have to worry about the 2 hours, putting on dry ice, etc.
Also for months or just for weeks? It's safe.
So for us, we just let it sit for a week. I have to double check with their instructions, but 1 week at least is okay.
Yeah, great. So dried blood spot cards. You tested for C1 function, C1 level, C4. Do you see any other opportunities in future to use this method for HAE diagnostics?
Yeah. I think I know. In fact, I think Professor Farkash has her own DBS, as far as I know, that looks for genetics. So that's another thing. If we can use genetics, especially because this is obviously only applicable for your C1 inhibitor, HAE type 1 and type 2. So if there were, if it was for the the normal level C1 inhibitor HAE, then genetics would be something that is promising on the horizon. So we'll probably want to look out for that one as well. Yeah.
Great. And so you're really also a very keen researcher in the field of HAE. And now, once this method is established, do you already have in plan some follow-up projects on this? Everyone maybe needs to know. I heard from something, but maybe you can tell the world what is your next big thing in this
So I
area.
think for us, we do need more baseline data. So as we mentioned earlier, Philip, the lead in our center, had done that Asia Pacific survey. But the Asia Pacific region is a very big region. Even within China, we have so many centers, and it would be really great to actually see where the problem is. To identify where the centers are, the so-called HAE specific centers, let's say, that do have these tests. And so I would imagine in the future we identify these HAE centers, and then the regions around that don't have these laboratory tests can easily and transparently know where to refer these cases. So I think more epidemiological studies will be needed for that, and that is in the works. We are collecting data with our collaborators for that, and excitingly, they also have, especially in China, they also have experience with DBS, and so we're working hopefully to see what the results of the DBS from those studies are, and hopefully we'll be able to share some of those results. And also upcoming, I do believe there is bigger global DBS study upcoming. So everyone should be on the watch out for that. So we're excited to help contribute to those studies.
And maybe final question, do you believe that in this region, Asia Pacific region, the use of these DBS cards will increase the prevalence rates known so far, or let's say the diagnostic rates of yet not diagnosed cases? What do you think?
Definitely. I think the diagnostic rates in our region has been low, and there are many reasons for that. And I think this is one of the main hurdles and barriers. The diagnosis is just that not enough, doctors or people know about the disease, let alone, order these tests. And even when you want to order these tests, you don't have these tests. So there are a lot of reasons for that. We believe that, HAE should be, the rates is not genetically based. It must be a socio-economic factor involved. So I think with the DBS, that would hopefully reduce some of these hurdles and barriers.
Great. So I think that sounds like a bright future also in your region, in the Asia Pacific region, to get people diagnosed. And I think, the correct diagnosis of HAE is the basis of treatment, of help to improve quality of life. That's really what we all want for treatment of our patients. And I think the DBS approach, as you said, and what you validated, what you published, is really the good opportunity to overcome these hurdles, barriers, and to get more and more people diagnosed. Jane, it was fantastic talking with you in these late hours with you about this topic. Thank you very much for your time and your availability. And I think we will talk about other topics sooner or later again.
Perfect. Thank you.
I wish you a great evening, good night. And people out there, if you have any questions to us, to me, or to Jane, if you wish to have other topics, new topics all around angioedema, please let me know. I would really much appreciate this. So have a great day. Thank you very much for listening. Bye bye.